Hi, my name is Terry Duran, and I'm a family nurse practitioner. And this is my case for the support of Senate Bill 680, which supports full practice authority for nurse practitioners in Michigan. So, the first thing we need to ask is what is truly behind this resistance for granting full practice authority for nurse practitioners? Well, the main movement behind this resistance is the American Medical Association. The American Medical Association is a very powerful special interest organization. On their website, they say for over 30 years, the AMA state and federal advocacy efforts have safeguarded the practice of medicine by opposing nurse practitioner and other non-physician professional attempts to inappropriately expand their scope of practice. And they even have an initiative called Fighting the Scope Creep. And they talk about how they have fended off attempts to allow full practice authority for nurse practitioners. The Michigan Academy of Family Physicians states, in the past, the MAFP has been successful in preventing the encroachment of nurse practitioners and other allied medicine professionals on the family medicine scope. So really, it's kind of about protecting their territory. You might hear an argument such as this. The bill would decrease the scope of practice for NPs beyond their current level of education and abilities. But the fact is, the National Professional Nursing Organizations define scope of practice for NPs based on education, certification, and role. NPs currently practice within these established national standards. This bill will define, not change NP practice or allow them to provide care beyond their education. The truth is that physicians are already not practicing at the tops of their licenses. So what does it truly mean to practice at the top of one's license? Well, each medical professional's routine activity should utilize the full extent of their education, training, and experience, and that their time should not be spent doing things that would be effectively done by someone else with a different set of skills. Now, when it relates to patient care, in some clinical settings, it is estimated that upwards of 80% of medical professional time may be spent performing activities such as clerical tasks that do not require a physician's level of training. So we don't pretend to say we are physicians, or we don't pretend to say that we have the same amount of education. I worked in a teaching hospital. Family physicians come out of school with massive debt and they are highly trained. They should be paid more and given more time to see the more complicated patients. Why do you think there's such a shortage of family physicians now? We can manage so much of what they do in primary care, and in some areas we can even specialize. Another myth is that the bill would remove the oversight by physicians, therefore increasing the risk of bad outcomes for patients. Now, this is certainly a myth. The fact is that the bill would define what activities are within the nurse practitioner's scope of practice only and will not impact quality assurance program requirements by healthcare and or insurance organizations to monitor outcomes and ensure safe patient care. In study after study, NPs are found to provide the same safe, high-quality care with similar outcomes as their physician colleagues. So truly, what does the research say? Since the NP role was established in 1965, research has consistently demonstrated the excellent outcomes and high-quality care provided by NPs. NP care is comparable in quality to that of their physician colleagues, demonstrated by numerous studies that conclude that no statistically significant difference across outcome measures was found. Research has found that patients under the care of NPs have fewer unnecessary hospital admissions, fewer potentially preventable hospitalizations, higher patient satisfaction, and fewer unnecessary emergency room visits than patients under the care of physicians. Empirical, peer-reviewed articles supporting the quality of NP practice are available, including original research, systematic reviews, and meta-analysis. And here is a link that you can go to, and there are multiple articles, 42 to be exact, only going up until 2020. So there are many that are available that are beyond 2020 up until 2022. Our next myth is that this bill would destroy the collaborative relationship between NPs and physicians. Now, this is just common sense. NPs, like all healthcare professionals, have a legal and ethical obligation to consult, refer, or transfer patients when healthcare needs are beyond the expertise and comfortable level of the provider. And NPs, of course, will continue to collaborate with physicians and all members of the interdisciplinary team to provide the best care for patients. Myth number 4, healthcare costs will increase because no one will be monitoring NPs' utilization of services. The fact is that study after study has found that NPs provide similar high-quality healthcare at costs dramatically less than traditional providers. Patients under the care of NPs tend to have reduced emergency room visits, decreased hospital length of stay, less costly diagnostic tests, and prescription drug costs. One study that the American Medical Association quotes on their website was done at the Hattiesburg Clinic. Now, it is interesting to note that the Hattiesburg Clinic is in the American Medical Association Health System program. Second, this data was collected by MDs, which does leave it open to bias, but it is worth looking at. Yet, it is one large clinic in Mississippi in the whole of the U.S. And as far as I can see, the study hasn't been validated. It hasn't gone through a scientific, rigorous process, and we really don't know anything about the dynamics of the clinic. It was data that they collected, and they made a clinic change based on that data. And now the American Medical Association is drawing blanket conclusions from that data while ignoring this whole body of validated research that states otherwise. But it's still worth taking a look at. So let's look at the realities of Michigan. Michigan's severe shortage of physicians is expected to worsen due to physician retirement. And I hear this all the time. By 2025, it is projected that Michigan will have a shortage of approximately 1,000 primary care physicians. Also, Michigan's aging population requires primary and specialty care to manage their chronic illnesses. And individuals who are uninsured and underinsured have increased difficulties in accessing specialty and mental health care. Primary care and specialist physician shortages are severe in the majority of rural and urban areas in the state, requiring residents to travel farther than the next county to receive appropriate care. And underserved rural regions are associated with higher chronic disease burden and higher cost of care. Also, Michigan is one of the most restrictive states for NP practice. Michigan is one of 11 states with the most restrictive scope of practice regulation, limiting nurse practitioners' ability to work at their full scope of education, training, and experience. So this needs to change if we want nurse practitioners to actually stay in Michigan. Restrictive scope of practice regulations limit nurse practitioners' ability to practice underserved rural and urban areas due to physician supervision requirements. The reality is that nurse practitioners will help fill the gap. Nurse practitioners are highly educated clinicians who traditionally practice in underserved rural and urban areas, delivering high quality, cost-effective care equal to or better than physician-delivered care. Research shows that in states with full scope of practice, more nurse practitioners practice in health professional shortage areas. Vulnerable Michiganders, so older adults and children living in poverty, have greater access to health care. Mortality rates for cancer, heart disease, and stroke patients have been found to be lower in those parts of the U.S. that have increased access to primary care. In critical care settings, research has shown that NPs reduce length of stay, time to consultation and treatment, mortality, improve patient satisfaction, and cost savings. And significant support exists for full practice authority. The Michigan Task Force on Nursing recommended that the state remove barriers to nurse practitioner practice that put Michigan at a disadvantage in cultivating an adequate nurse practitioner workforce. The Institute of Medicine recommended that nurse practitioner be utilized to their full potential based on their education and experience. Johnson & Johnson advocates for the use of nurse practitioners to fill the need for specialized, knowledgeable clinicians. Several other national leaders and national organizations, such as the National Academy of Medicine and the AARP, support full practice authority for nurse practitioners. So then I come to myself, and I did put a picture there because I didn't want to do a video, but it makes it a little bit more personal. I'm a family nurse practitioner, but when I got my BSN, I worked for 8 years as a nurse in medical surgical nursing. I then worked in cardiac step-down and became a charge nurse. Then I worked as a scrub nurse and a circulating nurse in cardiothoracic surgery. And we also did other surgeries, general, trauma. As an FNP, I have 20 years of experience in primary care, urgent care, community health. I developed healthcare curriculum for NPs. I freelance doing medical content writing. I'm an adjunct nursing professor. I prepare continuing education unit content and videos. I will graduate in May 2023 with my doctorate of nursing practice. And as our research project, we developed a migraine treatment guide for primary care providers, which is absolutely awesome, by the way. 4 years ago, I was debilitated by migraine, and I have spent that 4 years researching and learning and clawing my way back to health. Now, migraine is the second cause of years lost to disability globally. Despite that, there is so little education on headache medicine in medical school and in NP schools, and there is only one headache specialist per 80,000 people. I would like to open a practice that serves people like me. However, there is one barrier to me opening that practice, and it is the fact that I need to find a supervising physician. I do have somebody that is willing to supervise me. However, he can't because of his contract with his hospital. Therefore, I would need to go to the internet and find a business that finds collaborating or supervising physicians. And I would need to pay a supervising physician that I don't know, that I don't talk to, that I truly don't collaborate with, $9,500 per year to have a supervising physician on paper only. So I beg you and plead with you, please support Senate Bill 680 and allow me to have full practice authority so that I may serve migraine patients. Thank you so much for listening. Again, my name is Terry Duran.